So this again is mainly a few years of experience, as Mary Angela said. I'm using some of the knowledge I've gained from my colleagues at the NIH Gastroparesis Consortium, which is good news for the work they've done, and we look forward to continuing to do. So I'm going to try to combine knowledge from both sources and give you some of my own personal experiences and recommendations. So we all know this, but we always start with simple stuff just to make sure we're on the same page here. A problem with nausea and vomiting particularly. They think the two commonest symptoms that I see in my patients I ask about first are early satiety, inability to finish a normal sized meal, premature fullness, degrees of nausea, and abdominal discomfort or pain. And this can evolve into even vomiting, usually 3 to 4 hours later, sometime after a meal, even at night, old food from the previous meals, and heartburn evolving as well. Can get so bad you have malnutrition, dehydration, electrolyte imbalance from vomiting, weight loss, obviously, and basal formation. And for diabetics, your diabetic control becomes very unpredictable. It's about 4% of the population in the United States. Hard to get your hands around that figure, but we talk about at least 10 million people to 15 million, which for a population of 350 million, yeah, we're around 4%. Mainly females, and mainly young, productive years of your life, working and raising children. So a very negative, debilitating issue for quality of life. So these are the sort of patients sitting in my office most days, and probably some of you in the audience can identify with this kind of menu. The color slide's a bit old. It needs refreshing. I have been a bit lazy. That probably goes back 15, 20 years. On my right, I've kind of done a bit more updating. So in El Paso and many parts of the country, diabetes dominates. It's probably 40 to 50%. In other parts of the country, idiopathic gastroparesis gets up to around 30 or 40%, and maybe it's a bit more than diabetes. But idiopathic, we think, still unknown, but we think it's a post-viral or post-infectious encounter with something. Maybe a herpes variant, maybe some kind of gastroenteritis. It goes back to different forms of the viral infection. Could be a nasty case of even a bacterial E. coli, Shigella that we get from restaurants, traveling. It's hard to know what virus will come up with eventually. We see it in mononucleosis. Patients can get post-mononucleosis nausea and vomiting for a while. So it's a virus in transition. We haven't got cultures or haven't got any data yet, but good news is many idiopathics can resolve over months to years. Diabetics, on the other hand, of course, are stuck with a chronic disease. And then there's some other numbers and names here: connective tissue disease, such as scleroderma or lupus. There's a new kid on the block called hypermobility syndrome, which I'll touch on, which is a neurological, if you like, disorder that affects the gut, along with a sensitivity to pain. There are patients who have Parkinson's disease as they get older, and that can slow the stomach and the GI tract in general. Patients have had surgery. Can I point here?
No, I can.
Patients have had surgery. They can have their vagus nerve damaged, gastric surgery, often for fundoplication reasons. Patients who have functional dyspepsia, which is often overlapping idiopathic. So they're often postprandial nausea, bloating, fullness. I can't finish a meal, doctor. My gastric emptying may be borderline. We give that a diagnosis of non-ulcerative dyspepsia or functional dyspepsia. Medications, I'm finding a major change now in diabetics who are taking GLP-1 agonists, such as Trulicity and others, subcutaneously injected once a week to lose weight, help diabetes. That slows the stomach. And now the drug's just been approved for obesity in general. Take this GLP-1 agonist, lose weight, and maybe try to avoid the complications of obesity. So we're going to see much more of that. Medication-induced problems. Opioids are always in the picture. Marijuana. It's not been talked about much. Many of you take marijuana, probably out there to relax, to help your nausea, to try to think it helps your appetite. But there can be a cost. We think that daily use of marijuana after a few years can be dangerous and induce a condition called cyclic vomiting. And even without cyclic vomiting, we now know that marijuana is impure. It used to be, very puristically grown and harvested. Now it's fertilized, it's contaminated. We see many pictures of the sap being changed on the tree, on the plant, and there's a whole world now of toxic marijuana. So some patients who smoke marijuana can get sick within weeks or days. That's a toxic effect from really contaminants in the plant. Let's go on from there. So a summary again, 40% of patients have refractory problems leading to surgery, and that's when we can obtain tissue or biopsies from your stomach and pylorus while you're asleep. And what we've learned from that is that if you look at this diagram here, I show you a sort of up-close picture of your muscle, and these dots, these are cells in your muscle, which are called the interstitial cells of Cajal. And as well as that, you have these other cells in there, which are the enteric nervous system, so the enteric nervous system's connected to the vagus nerve, and we help stimulate release of acetylcholine, nitric oxide. The interstitial cells of Cajal, shortened to ICC in the lower slide, activate your electrical complex, your electrical signal, which tells the stomach when to contract. And that can be depleted in nearly 40% or more of patients who have chronic gastroparesis. So we've got on the side over here, the big picture, if you like, the fourth nervous system. You've got the CNS, the autonomic nervous system, spinal cord system, and then you've got the enteric nerve system in the smooth muscle called the myenteric plexus, and then you've got the ones under your mucosa called the Meissner's plexus, which is the one that helps you with absorption and secretion. So impaired nervous function from the enteric nerves, vagus nerves, and impaired smooth muscle electrical signals from the interstitial cells of Cajal, and your muscle is confused and doesn't contract well, and your pylorus does not relax well. So it's a double whammy to make your stomach slower. Next slide. And this is the way we measure it. We do what's called the electrogastrogram. We put electrodes on your tummy. Not all centers do that down here. And we show a signal which in the top bracket is very irregular, what's called tachygastria. And then the bottom one, a nice regular one from a normal subject, I assume. And it's been studied and shown that the more you lose these interstitial cells of Cajal when they fall below the magic level of 10 cells per high power field, the more likely your electrical rhythm is irregular and erratic, and your muscles don't contract properly or not in a regular pattern. There's no peristalsis. Next slide. And so the work for the NIH, you might ask, you know, why was I chosen? There's many diabetics out there, and there's many idiopathics out there. My sister is in your office and I'm not. Why did that happen? Well, we believe that there is an insult going on, diabetes or a viral activation of inflammation. And what's key here on the slide here, you see the word M2 macrophages over here and M1 macrophages. So we believe the M2 guys are good. They try to keep peace and maintain your interstitial cells of Cajal, maintain your nitric oxide and enteric nerves, and sort of keep the status quo. At a point in time, you cross over and M1 macrophages dominate, and they are associated with impaired interstitial cells of Cajal, impaired enteric nerves, myenteric plexus, and gastroparesis. So one of the goals of the NIH and other places is to find ways to affect the M2 to M1 transition, prevent it, prophylaxis, prevent the cascade of events starting. Once they've started, it may be very difficult to restore order again. So a lot of work is going into ways of preventing this transition from M2 to M1 from taking place. Next slide. So let's talk about, for the rest of the time, you know, how we can treat you. So this is a menu of what's out there. It's been the same menu, I don't know, for a long time. Maybe I need to upgrade it, but there's been a few updates. But let me go through what I think is relevant to you in the time we have. Next slide. So when you're sick and you want to feel better by Friday night, or even tonight, all roads lead to antiemetics. You need an antiemetic to help you today. We need to block the chemoreceptor trigger zone, which has cholinergic receptors, dopaminergic receptors, opiate receptors, serotonin receptors, and in some cases, menstrual cycles, it has pregnancy, probably has estrogen and progesterone receptors. And so we attack those receptors. That's the theory behind antiemetic therapy. So we give promethazine or compazine. It's kind of a combination of blocking anticholinergic and some anti-dopaminergic. We give Zofran. That's a 5-HT3, serotonin 3 receptor. That blocks that. Amen is a variation on that. And it blocks a receptor in the chemoreceptor trigger zone. Scopolamine patch, anticholinergic, mainly. Marinol, mainly. Anti-cannabinoid, anti-opiate, a marijuana type appropriate, kind of a way to affect the THC receptor. And then we have motility drugs that in some cases do double duty. They block nausea at one time, and then in the stomach, they block dopamine. So they block dopamine in the brain at the chemoreceptor trigger zone, and they block dopamine in the stomach and release more acetylcholine, and your stomach contracts and empties better. So you all know about metoclopramide. What's new with metoclopramide? It's very exciting. First time in since 1988 or something? We actually have a new kid on the block, in a way, for motility. That's Jamoti. Jamoti is a nasal spray form of metoclopramide. It's got a 3-month approval, so it's probably under the window of any dyskinesia or any concerns about Parkinson's. It's absorbed despite vomiting. It avoids the liver. It goes straight to the circulation. It sustains a long pharmacokinetic half-life in the serum. And it's really probably the drug of choice as far as replacing oral metoclopramide. It guarantees absorption whether you're vomiting or about to vomit, or whether you've got a B-sore, this goes straight to the receptors in your stomach and stimulates motility and blocks nausea in the brain. So this will be the drug of choice for everyone out there with gastroparesis as far as first-line therapy. 3-month approval, really no side effects to speak of. Maybe some agitation and restlessness in about 5% of people, but everyone else can tolerate it. So erythromycin we'll talk about, and we'll talk about motilium. This is the year of domperidone. This has been the comeback year. Domperidone's a hot ticket, and I'll explain why. And then we have brain-gut modifiers. If you're depressed, nauseated, losing weight, we might recommend mirtazapine, Remeron. If you've got a lot of pain in your tummy, as well as being nauseated, perhaps depressed, Cymbalta might be your drug of choice. And I use, as sort of an amateur psychiatrist, I use a lot of tricyclics, TCAs, amitriptyline, 10 to 50 milligrams before bed, regulates the brain and the gut. Some people have symptoms, intolerance, we give nortriptyline. Next slide. So when you give metoclopramide in the past, we had to make sure that you did discuss some of these side effects, because the black box says after 3 months we should stop it. But quite frankly, that's not realistic. 3 months is nothing in the career of a gastroparetic. So we will be using this drug beyond 3 months, and we do use it. So you need to go over the side effects and make sure the patient realizes about Parkinsonian tremors, twitching and facial movements, tongue movements that make up the world of tardive dyskinesia. Very rare. I never seen a case myself in my own patients. If you follow people religiously and carefully every 3 months, it won't happen. But these are warnings that need to be mentioned to the patient and the family so that they understand. Breast enlargement, nipple tenderness due to prolactin can occur, but if your nausea is better and you're feeling better, that usually does not lead to stopping the drug. Next slide. So domperidone's been around for 40 years in Europe, never been approved here. It's approved everywhere else. It's in Mexico, which is about 5 minutes from El Paso. So many of our patients get it anyway. But this shows why it was approved in all the countries in the world. Major effects on particularly nausea and vomiting and general satiety, fullness, and eating. Next slide. Why do I say it's the year of domperidone? Well, we have Dr. Sorosiak's and my trial and the NIH trial that was just published last month in clinical hepatology, gastroenterology. And this was the work of obviously many of our colleagues in the NIH consortium, but we showed that despite the best efforts of all our colleagues, some patients weren't doing well. When we added domperidone, usually around 40 milligrams a day, they were better after months and years, better than standard medical therapy, the best we could give. And then recently, I and Dr. Gajendran are publishing an article to reassure you that high-dose domperidone, greater than 40 milligrams, we go between 80 and 120 a day, is safe for cardiac toxicity and gives you good clinical relief. So domperidone has a red sort of dot. It's a positive drug now. You should be able to obtain it through certain pharmacies in Canada, and also through what's called a FDA mandated NDA. I and other people have it. You could certainly send a message to Joan Bishop, and she could send it to centers like mine where patients need domperidone. We could help them. Or you can go to Mexico. Next slide. So erythromycin's always been in the background. It's sort of a backup poor sister. We can use it while you're waiting for better ideas. It may help your gastric emptying for a while at 250, low dose, 3 times a day before meals. Usually no side effects, but it does wear out as far as its efficacy after 3 or 4 months, probably. You could take a holiday and use it again. Or you have to use antiemetics with it. It's not an antiemetic. Patient will not be happy just on erythromycin. Next slide. Aprepitant. Aprepitant is a new kid on the block called Amend. It's going to be useful in our world. It was pioneered through chemotherapy. This is a paper that we published through the NIH, and it shows that it has mixed effects. It's not a slam dunk, but in a double-blind trial, patients on aprepitant or Amend, the dose is what, 20 milligrams, I believe, somewhere there, a day. They were able to decrease their nausea score and feel better. The whole package may not be better, but nausea particularly is the one we focus on. So it's a bit more expensive than, it's 125 milligrams a day, a bit more expensive than ondansetron, but it's there as the next line of therapy, trying to help attack a different cause of nausea in the brain. Next slide. And these are the kids on the block now that are coming up. Vanda has a drug called tradipitant. It goes beyond aprepitant in being an NKY. It's what's called an NKY antagonist, a neurokinin agent, and it's getting press. It's being approved. It's been released in good publications. The FDA has not mandated anything yet. It's not approved yet as an antiemetic. Ghrelin agonist by pharmaceutical company called Rhythm. They have stopped their studies. So unfortunately, Relamorn will not be with us for different reasons, mainly because it was too effective and the glucose went up after you gave it. Volucitrag is being readied in Europe. We may see it over here. It's a 5-HT4 agonist. Prucalopride is here for constipation, and now by Takeda. I'm using it when we're desperate. It's called, what is the name? Motegrity. Motegrity is the name for constipation. You can use it 2 milligrams a day for gastroparesis. And then we have the nasal form we talked about, Jamoti. We have a domperidone lookalike that's now going through trials by Takeda, which will be ready by the end of the year. The trials will be analyzed. And Neurogastrix is another form of a dopamine antagonist that's being prepared in the wings. Next slide. Again, TRICYCLICS can be given to try to help patients. Some of our patients really have extreme anxiety, depression, maybe present before these issues with their stomach started, maybe exacerbated by the fact that no one has any answers and their life has been changed and they need help. And we believe that improving their brain-gut relationship, symbiosis, makes them more motivated or makes them more able to overcome, tolerate the nausea. So it's an antiemetic in a way, low dose, and we use 10 to 50 milligrams at night as a rule before bed. We build up from 10 to 50. Next slide. The neurostimulator Entera system that Tom Abel and I pioneered earlier on, and Dr. Rosiak pioneered with us at Kansas and now here, is alive and well. It's been around since 2000. We now know it doesn't work by emptying the stomach faster or by just reorganizing your gastric rhythm. It mainly affects the centers in the brain near the thalamus, where the vagus nerve is, dorsal motor nucleus. It's an antiemetic. It's probably the world's best antiemetic. That's the way to look at it. So after you've gone through all the rest, aprepitant and all the reglans and domperidones of the world. This is an antiemetic, and this could be your next step in the name of uncontrolled nausea and vomiting, admissions to hospital. Next slide. Pain control always on the table, always under-recognized by doctors. We say it's just discomfort, it'll be okay. Patient really believes it's much more than that. They're in the emergency room getting CAT scans and IV narcotics, and it is a serious issue. We rule out simple things, gallbladders syndrome called the median arcuate ligament syndrome, where the celiac ganglion is compressed. And sometimes we make sure it's not irritable bowel syndrome. You can start with NSAIDs. Tramadol is okay, 50 milligrams up to 4 or 5 times a day can be tolerated. Got to be careful you don't give it with an SSRI, antidepressant. You can cause a serotonin syndrome, agitation, restlessness, very tachycardia. Cymbalta is a drug of choice for pain. We're moving more into gabapentin and Lyrica, trying to modify pain. These are neuromodulators. They're not narcotics. We try to avoid, narcotics at all costs, and we try to work on some pain management clinics, maybe as well, to withdraw them if they are on pain medicine. We give them methylnaltrexone, Relisto. Relisto is a drug we give once a day to block the GI effects, but sustain the pain medicine component, relieve pain. New kid on the block, on the next slide, is what my colleague next to me is working on. Karina Espino and I are working on virtual reality. This was pioneered at UCLA, Cedars-Sinai specifically, where patients meditate and breathe, distract, and at the same time go off to desert islands, rainforests, swimming under the water with fishes and porpoises, and try to relax and meditate for about 30-minute sessions and try to get the body used to ignoring, living with, accepting, trying to accommodate to degrees of nausea in their lives. The goal of this company is to have this marketed so you can prescribe a virtual reality headset and program as a prescription at a pharmacy. Take it home and use it. 1 session a day, whatever. We're doing 2 or 3 a week as outpatients, but we are seeing some improvement, and we think this is on the table for helping. Next slide. And then the evolution of trying to do something more radical. We know that the pylorus down here, pyloric sphincter has to open and coordinate with the stomach contractions and empty. We now know that this area of the stomach, the pylorus, can have loss of interstitial cells of Cajal, particularly after a vagotomy is done by a surgeon during a fundoplication, or particularly in diabetics. And when you lose those cells, the muscle doesn't relax. The nitric oxide is affected, along with the stomach, which is also in part in play already. So there's been a big move to cut the pylorus. Next slide. And that's been achieved by the surgeon by doing what's called a Michelitz Heineke fundoplication. Pyloroplasty goes back to German days. Dr. Davis here has evolved it to a laparoscopic procedure, and this is work from a group in Portland, Oregon, where they show that after a pyloroplasty, your symptoms can get better. How do you know that? Well, this is the weak link. Before surgery, we need to do a study called ENDOFLIP. We put a little funnel, looks like a funnel, in your pylorus, and we blow up a little balloon around that funnel, and we see how tight does your pylorus constrict and stop the balloon from expanding. A very tight, a very non-compliant pylorus is a signal that if you can cut that muscle and open the door, the patient will feel better. So we are recommending ENDOFLIP to all patients who have gastroparesis to see if their pylorus is really so bad that the medication we're giving is not going to work. Let's move ahead and get to the money, get to the point here and do a pyloroplasty. Next slide. And you can do it by surgery or you can do it endoscopically. Some of my colleagues are becoming very aggressive and doing an endoscopic pyloromyotomy called a GPOM, which is a name for a gastric poem, as opposed to an esophageal poem we do for achalasia. But a big question was recently answered by Dr. Sorosiak and I was, does a gastric stimulator help, or does a pyloroplasty alone enough? And we just presented a study at DDW, which confirmed in a double-blind fashion that a patient who gets a gastric stimulator and a pyloroplasty, surgical, is better than a patient who just gets a pyloroplasty. The main symptom, vomiting. Vomiting after the surgery, requiring ER visits, quality of life. That's taken away by using the stimulator. So combination therapy right now is the state of the art or the optimal therapy. Next slide. I think we're going to finish up here. We've got about 5 minutes. I want to make sure we don't miss a lot of other causes. You know, everyone believes they have gastroparesis when they vomit. That's not the case. There's a condition that's been around for a long time. Back in the 1800s, this was diagnosed, 1900s, I believe it was, in by pediatricians called cyclic vomiting syndrome, particularly in children with migraine. Now it's evolved to adults. Dramatic cycles of vomiting and pain, at least 5 or 6 a year. And I usually every month or two, they're in the emergency room. Pain and vomiting. Next slide. It's mixed up a bit now with marijuana-induced vomiting called cannabinoid hyperemesis. We see it every night in the emergency room, usually missed by our ER doctors. These are patients who don't admit to it, but they're smoking marijuana chronically, typically males, and they have dramatic attacks of pain and vomiting, often relieved by hot showers and hot baths. But this is a confusing diagnosis. If you're a diabetic, it doesn't mean you have diabetic gastroparesis. It could mean you are just having cyclic vomiting. On the next slide, the treatment is very different. You know, these patients are treated by high dose TRICYCLICS, up to 100, 200 milligrams a day at night. Anti-migraine, anti-anxiety. Anxiety and stress is everywhere, and those patients respond. Next slide. Another diagnosis that I'm sort of saying is probably the diagnosis of the year. On the next slide, I'll come back, sorry, I missed it, is what's called rumination syndrome. Okay, this is epidemic. My colleague next to me, Karina Espino, and I see this every day. These are patients who talk to you about, gee, doctor, I'm vomiting so much, I can't leave the hospital, no one can help me, I can't eat anything, I can't even drink water. Do something, you know, operate on me, do anything. Well, the main thing is to take a history, talk to the patient. These patients have a condition called rumination syndrome. Within 5 to 15 to 20 minutes, water and food come back into their mouth in an effortless manner. It's effortless. They're sitting at the table with their friends. It comes up. They have to go to a trash can. Belching and degrees of hiccuping sometimes, feelings of trying to expel air and belching precede the effort. It's a belch reflex. There may be some nausea between attacks. The main other symptom is pain in your tummy. From vomiting so much, you hurt your muscles, your rectus muscles, and that's called Carnet's sign. And you need usually hot pads or lidocaine patches to try to help people. Every day, every meal, rumination. What do you do? Well, next slide. We think it's this sudden dramatic belching reflex that brings up food within 15 minutes of eating. When you go back, there's been a major psychosocial event in their lives, loss of a loved one, a post-traumatic stress event in their own personal lives, Physical or sexual abuse is common. Loss of a job, financial concerns, marriages, relationships. There has been a significant event when you finally delve into their history that activates this syndrome. And the stomach becomes programmed. Every meal, every day, the stomach has been hijacked. Next slide. We treat it by teaching the patient diaphragmatic breathing, relaxation, meditation. We give them literature to read during the meal to relax them, to think of good things, distract them, so they will not be tempted to give in to that belch reflex and vomit. This can take 2 or 3 months. And during that time, Karina is doing a lot of the so-called virtual reality programming to reinforce this relationship of trying to ignore and overcome and distract the patient from wanting to vomit. We also give tricyclics at night because these stomachs are very sensitive and they also have stress in their lives and their sleep pattern is often disturbed. Next slide. So tricyclics, proton pump inhibitors for the acid that comes up, stop the burning, some antiemetics before, during the attacks. They have nausea during the day, and using hot pads or sometimes lidocaine patches on their tummy. Next slide. Hypermobility, need to mention it. It's very common. I always ask about it. These are patients who have hypermobility characteristics. Their joints get out of, they're double jointed. Their joints often get out of their sockets and come back. They can twist their finger, their big finger back onto their wrist and do different things with their arms and legs regarding all sorts of contortions. These people have an associated syndrome on the next slide. It's part of the Ehlers-Danlos syndrome. It may be a family history of connective tissue disease, but when you see unexplained nausea and vomiting, you see excessive pain after you eat a meal, we call it visceral hypersensitivity, unexplained nausea. In a young patient, we investigate the possibility of this syndrome. It doesn't mean we have a magic cure. It's a neurologically driven syndrome. Some patients have what's called POTS, rapid pulse rate, and they can sometimes faint when they stand up. That's a different entity, but 30%, 40% of our patients have POTS syndrome plus Ehlers-Danlos. But it's a way to talk to the patient to say, we have found a connection here. We're not going to turn everything around today, but we do have plans. Some people are using different ways. It may be a neuropathy kind of drug, a gabapentin type of drug. Sometimes we just use a lot of antiemetics. Sometimes we use some other drugs to minimize the so-called visceral hypersensitivity, including the tricyclics and the metazapines and these drugs. Next slide. I'm going to leave it there. I'm speaking to you from Texas Tech University Health Sciences Center here in El Paso. Thanks to a great team I have here and the support and funding of the NIH, we've been able to try to advance this problem and hopefully help some of our patients. I hope we have a few minutes for questions. Thanks for your attention.